a little over 2 years, I had been at Vanderbilt, when the accident itself happened. My unit was the neurosurgical ICU. That was my unit. The role that I was working in was called a help all. That is a staffed position in our unit and probably in other ICUs as well, but in our unit, I know for certain there was a person in that role every single shift. Day shift, night shift, weekends, holidays, it didn't matter. There was a charge nurse, there was a help all. So this particular mistake, I'll try to short summarize it because a lot of people know.
Yeah.
The patient was a step down patient. Again, I'm a help all nurse. I'm not taking patients as an assignment. I also have this young man who is with me. He is my orientee. He's maybe 3 or 4 weeks into his orientation. One of the reasons that he was with me and I was in the help all role is because there is a mandatory day in his schedule where he is supposed to be with the help all. They need to see what the help all can do as a resource so that they know what to call on. And it also gives them the opportunity to step in and out of multiple things throughout the course of a day so they can look at different skill sets. This was a step down patient who had already left and went downstairs from the 6th floor of our critical care tower to the 1st floor of the hospital, which spreads out everywhere, and was somewhere in the radiology department already by herself without a nurse and without a monitor per the doctor's orders. Okay, monitoring had been discontinued, permission to leave the floor, without a nurse, without a monitor. All
Per
that
the
was
doctor order.
the
I
doctor
want you to double down
per
on
the
that.
doctor's order. Per the doctor's order. Okay. This patient had a history of claustrophobia and anxiety, which I found out well after the fact, looking through her medical records. She, sometime after lunch, when vitals were checked, her blood pressure was high. She had already talked to the staff that morning, the neuro folks. They knew PET scan was going to be planned. She'd had multiple scans, MRIs, CTs over the past 72 hours, some with unpleasant experiences. Again, all of that I'm recapping. I had no idea about any of this. Was well known and documented that she would need something for anxiety if she was going to go sit still in any kind of enclosed space. She was freaked out about it. Nothing was done. Nothing was ordered. No PRN pill was ordered for this. Nothing. So lunch rolls around. They check vitals. She's hypertensive. Why do we think she's hypertensive, Maggie?
Well, I'm sure she's anxious. She's going down to, or am I, oh,
And what do we do?
well, we're not
We give her IV medication
hydralazine.
to lower her blood pressure. Do we put her back on a monitor? Do we try to anticipate why? No, we just treat. We just treated the numbers on the screen. And, an hour or two later, she left and went downstairs. Again, all of this, I'm painting this picture for you. I didn't know any of this information. I knew none of this. All I knew was at 2:45-ish, I got a phone call from a guy working in step down, a nurse that I knew from our unit. Hey, I got this patient. They're downstairs already. PET scan's calling me. She's already had her radioactive tracer, the radioactive glucose. They're telling me if she doesn't get something for anxiety that they're going to have to cancel it. She's going to have to come back upstairs. This is going to postpone her discharge planning. They want this done prior because they think it's a tumor with, mets to brain situation. They need this before they discharge her. And if we can't get it done, then, it's day after Christmas. It's skeleton crew. They don't have, it's pretty, what you're doing is what you're doing that day. You don't have extra things to work with. So that made sense that if we didn't get it done now, there was a sense of urgency, not an emergency, but urgency. So he's asked me to go give this medication to her, tells me what it is. All right, I accept. Ask him, do I need to take a monitor down? Do I need to monitor the patient, stay with them? No. No monitor. She has permission to be off the floor without a monitor, without a nurse. Okay, he can't go because he's watching his other patients and his next door neighbors. Fine. My orientee are also heading down to the ER. We're going to go do a swallow study on a stroke patient that's not coming to the ER. We had an ICU nurse available and speech wasn't available. We would go
Yes.
down and we would, at least take care of that aspect so that they could determine medications, right? Can we do oral? Do we need to do IV? What do we need to do? That was on the list. So great. That's a good thing for my orientee to practice at. We're going to do that. Sidetrack. Okay, now we're going to go do this thing. So I'm looking for the med. He tells me what it is. I look in her profiled meds on whatever we were using, Pyxis, Acudose, Omnicell. I don't remember what it was. It had changed from one thing to another in preparation of launching Epic, but I don't remember what we were on at that time. Couldn't find it. Called him back. Is it there? I can't see it. Is the verbal
So you
order?
call who back? So
The nurse,
okay.
the primary nurse. Hey, I can't
Okay.
see it. Is it a verbal order? Did you put this in? No, it's there. He put it in. I've already acknowledged it. Cool. Go to an empty room, pull up the computer, pull up the patient, find her MAR. There it is. Versed, 1 to 2 milligrams as needed for PET scan. I could also see in the previous 24 hours, she'd gotten Versed for, I think it was an MRI. Okay, making assumptions here. This must be the drug of choice. I don't know why. Again, I also don't know that when she did get the Versed previously, she was still a critical care patient. She was still in an ICU bed. She'd just been transferred out either
Very good
the night
points.
before or that morning. But we're a shared kind of open unit, right? But I can see she'd gotten Versed before, so my assumption is must have been the drug of choice. Generally, we would use Ativan, or we would just give you something by mouth.
Oral.
Orally would be preferred if that's a route that it's appropriate for you. Your A&O, and we're not worried about a decline in your neurological status. That would obviously be the preferred route. So see this on here, write down the drug order on this lab baggie that I pulled out of the medicine, like out of the stock cart in the room. Got some alcohol swabs, got some flushes, got a blunt tip needle, logged out of her chart, put all that stuff in the bag, went by the desk, and I got a sticky note with like a peel and stick sticker from her file. I stuck it on the back of my badge so I'd have something to identify her with. Back again, still can't find it.
Where can't you find it?
In the automated dispensing cabinet. So I have pulled up the patient's name. You have profiled drugs under 3 categories: routine, stat, PRN. Should have been under stat and PRN. If I would have scrolled long enough through routine, I probably would have found it, but it should have been under stat or PRN because it was a PRN order written as a stat order. It's not there. It isn't there. So this is the 3rd time that I have tried to find this medication. It isn't there. The 4th option is override. Okay. And I'm going to tell you why I was so quick and, to choose that. I'm going to say quick after 3 times of looking.
I was about to say, I wouldn't say that was quick. You did,
After 3
you
times
did
of
wait.
looking,
Yeah,
right?
you did to the 4th time.
I went to that. But I didn't hesitate at that point to make that decision because there were known issues with drugs communicating through the electronic system to the dispensing cabinet. We would see them ordered, pharmacy would have them verified. No one can find the problem. All we know is that it's taking an indefinite amount of time for this drug to show up under the patient's profile. So we're having to override. Also, override once we launched Epic. All of this happened when we launched Epic, which was 2nd week of November. About 6 to 8 weeks prior to this happening. I can't remember exactly, but 1st or 2nd week in November is when we launched. Having the issues with the drugs coming through. Now, also, the override is the rule, not the exception for a multitude of things. IV fluids.
Always, or just because of this?
Always. I don't know if it changed. I just know that that's how we obtained them. Override. Patient specific drawer. Override. Medication fridge. Override. Key for the Ativan box. Then to access the fridge. Then to put the key back. Override. So overriding was the rule, not the exception for those things. And it was also becoming the very well accepted exception, workaround, for not being able to access drugs that you needed for patients in a timely manner. So therefore, you have to, right? You have a choice here. Do you delay the drug? What do you do? Right?
Or in
Sometimes
this case, the patient had been given an isotope and radiology is waiting for you, right?
correct. And I don't know. I just know the clock is ticking.
Yes.
I remember from nursing school, I had 45 minutes to an hour to, she had to be in the scanner. And it's my assumption that the time is ticking. I know it takes a while for all of that stuff for her to get down there, for that to happen, probably for them to assess her anxiety level, calling back and forth. The time is ticking, and I still have to get down there, and I don't know where I'm going. I haven't been to PET scan. So time is ticking. It's probably been at least, 10, 15 minutes since I've gotten this phone call. I still have to get down there, give her the medication. They're waiting. So I type in, override, I click the screen, type in Versed. It can be done all with your left hand on the keypad if you are a normal, not a pecker, but normal typer. Um,
Right.
all 6 characters can be typed in with your left hand. I typed in all 6 characters. A drug pops up on the screen. I select it. There's no warning on the screen. The box comes open, the little cabinet pops open. I grab the drug out, close it back, close this up. That's it. We're on our way now. At some point, I did recognize that this was in a powder form and not a liquid form. Again, things you become used to over time. Now, this wasn't a workaround as a traditional sense, but it was something we had gotten used to seeing. Hurricane Maria came through September, I think, of 2017. Puerto Rico, the people of Puerto Rico, like it was one of the worst hurricanes to hit Puerto Rico. Like 3,000 people died. It wiped out.
Supply chain
It wiped
in
out the
the
supply for
nation.
drugs for the nation. The district attorney laughed at this,
That, you know what?
but every time I've spoken to people all across the country, every time the whole room is like, oh,
Oh yeah, absolutely. To your point, I remember working in the cath lab and went to pull out Versed for sedation, and it had a green label. And I know it to be always orange in my experience, but as a seasoned nurse, it spurred me to, even call the pharmacy and say, "Oh, hey," who then said, "Yes, due to supply chain issues, we are getting drug supplies from different, companies, and it can appear differently." And there was no email that was generated. So yes, to your point, we were using different supplies. I think that is a very valid point.
and I tell people this because I am not making excuses. I am painting the portrait for you of exactly how this happened, of how I normalized these things and rationalized making these decisions in my mind based on what the the bubble of nursing where I was, based on what was happening there and what I had been experiencing. There are reasons we factor in. It's called human factors. There are reasons we do the things that we do. The only true way to fix the problem is to understand why the human did what the human did. So that's why I tell people this. It's not an excuse. You have to understand what I did in order to not do that yourself or to prevent this. So here I am. The drug is in a powder form. For the last 3.5 months, we were seeing all kinds of things in powder form that we were having to reconstitute. Antibiotics, all of our antibiotics, almost every single one of them, we were reconstituting. Unless it was like, a vancomycin, 750 milligrams, kind of standard thing. We were reconstituting steroids. I mean, lots of things we were seeing in different formularies. You might open up a cabinet, and a drawer pops open and you look, they're very different.
Yep, yep,
Same, but
yep.
different, right?
And they didn't send out any emails, or they didn't. I know they didn't, because they didn't tell any of us.
Yeah, no, we were aware. We were aware. Our pharmacy, we had a pharmacist like at the back of our unit, right outside the door. There was a little satellite pharmacy. So we had good relationships with our pharmacists, and we were aware. We knew that there were things that were changing constantly. Like this was going to be the norm, and it was going to be the norm for a while. So again, pull this out. It's a powder form. I don't even think about it. Also, generally, this has a red top, right? This one had
Yeah.
a gray top. It had a gray top.